Hi there. Thank you for joining me once again on the program Your Doctor and COVID. I'm your host, Dr. Mahendra Carpen. I'm the head of medical services and cardiology at the Georgetown Public Hospital Corporation. Today we continue our discussions around the COVID-19 pandemic, and we're very grateful that you're able to join us either by viewership or by listening to this program. Also very grateful that you've been sending in your questions, your comments, and we want to encourage you to keep on doing so. Remember, if you have any questions or comments, feel free to send a WhatsApp message to 620-6275, or you can send an email to docandcovid@gmail.com. We know the pandemic has been raging across the Western Hemisphere. Guyana has not been spared, and many of our friends and allies overseas have been touched by this on a personal way, and many of them Guyanese, many living abroad, many with friends and family still in Guyana. Today I am joined by a good friend of mine, Dr. Dion Vigilance, who is Guyanese by birth, spent a lot of his early years in Guyana, and has elevated himself to becoming a leading heart surgeon in Pennsylvania in the USA. So I want to say a special welcome to Dr. Vigilance as he joins us on the program today. Welcome, Dr. Vigilance.
Thank you for having me. Pleasure being here.
So you and I have been asked to be on this program today. We are about 7 feet apart, and I believe that is a safe distance that we can take our masks off for the remainder of this conversation. You yourself have been vaccinated against COVID-19, is that correct?
Correct, yes. I received the first dose of the Pfizer vaccine.
Good. So that's very good to know. So for the rest of the program, we will take the masks off.
Thank you.
So I just wanted to get your input, your thoughts, and your assessment of, the way the world has changed in the COVID era. How do you see these changes playing out in your new home in the USA?
Yeah. I'm going to start from both a personal perspective, and then I'll kind of go and talk a little about the medical aspect of it.
Yeah.
First of all, I realize that our teachers are probably the most underpaid and undervalued members of our society. And that's as a result of homeschooling.
Yeah.
Since this pandemic, we really had to do a lot to, try to educate our young ones at home. And we have 3 young ones at home that we're currently taking care of. So that's been my first experience. The other thing that happened is, from a professional standpoint, I have never had more than 1 week at a time of vacation. And ironically, when the pandemic first hit, I was at home for almost a month straight. And that was very brand new to me for many reasons, not just missing work, but also being so engaged in the family household activities on a daily basis. So I think from another professional standpoint is that we've never closed down our operating room. So that was very interesting for me to kind of experience as well.
Yeah. When the pandemic hit, most of the world, or at least the Western world, were taken by surprise, or it appeared that way. No one seemed to be fully prepared. There was not a really organized approach to how to manage this. And you practice in a very big hospital or hospital system. How were the early days of the pandemic treated in your neck of the woods?
For us, it was just the same as probably anywhere else. We weren't prepared, we were ill-equipped, and we were not as informed as we thought we were. As a result of that, we became very reactionary to the process, and there was a little bit of a kind of, say, a proactive approach. And what I mean by that is, what we did initially was, instead of understanding exactly how the virus is transmitted, how do we kind of protect ourselves and care for patients who have COVID, and at the same time run a business as we normally would in the hospital. So what we decided to do was to stop all activities at one point, shut everything down, and really focus on COVID and COVID only. Mm-hmm. And we learned a valuable lesson from that initially, which we've adapted to. But yeah.
Tell us about that lesson, because I believe that's a very important lesson that everyone around the world who has followed that model has learned, and they've learned it the hard way.
Yeah. I think we'll realize that not just, I think a lot of the community take their cues from, particularly when it has to deal with medicine and healthcare, they take their cues from the leadership in those organizations, meaning the physician most of the time. And we reacted by saying, you know what, we don't want, or we should not be operating on patients during COVID. So for me, I'm a heart surgeon. Probably one of the most important organs of the body is the heart. And we decided not to operate on any patients with COVID at that time. And then we also shut down all operations at a time. And what we realized that a lot of patients were coming in with major heart attacks, and people were actually dying at home from heart disease and heart illnesses. The other thing that happened is by us shutting the entire hospital down, we really affected ourselves from a financial aspect. And I think as a result of that, when the second and third wave came through, we decided that we're going to manage ourselves by living with COVID and being able to manage patients with COVID alongside other patients that have other illnesses.
Yeah. So there has been a recognized increase in excess deaths in the COVID era.
Sure.
Did you see that in your own hospital system, in your state in the US, where if you were to compare the COVID deaths versus the number of deaths that occurred from other things, for example, heart attacks, strokes, etc., that where patients did not choose to come to hospital, do you have an idea of the ratio that represents?
Yeah, in some cases, we probably said, we actually attribute patients who died from COVID and said, these are the numbers of COVID deaths. So as of today, there are about 19.4 million patients in the United States with COVID. There are about 335,000 deaths to date, with there being added about a little over 1,800 cases from yesterday.
Wow.
What has taken place is that we have realized is that 2020 is going to go down as the deadliest year in America. And on average, we have about 2 million people that die a year. This year, we're going to approach about 3 million people. Now, I just mentioned that 335,000 patients we know died from COVID, and those are patients who were in the hospital and died from COVID. How do you account for that additional
600 plus thousand?
So basically what we're saying is that about 2/3 of the deaths, that additional deaths or incremental deaths that occurred in the United States in 2020 could be from other reasons, not directly. Some of those could be patients with COVID who died at home, but could be patients who died at home because they weren't seeking care or we weren't able to get to them in a timely fashion, and they died as a result of that, subsequent of the COVID that we were so focused on.
Yeah, or it could be that these patients actually did make it a hospital, but resources, etc., were completely focused on COVID.
That's a great point. So what tends to happen is, there are hospitals that are running out of ICU beds. So you made it into a hospital, you need a bed, and maybe they're shuttling you from one facility to the next because capacity ran out. As a result of that, someone could have expired on the way to another hospital, could have expired while waiting for a bed, didn't get the correct care. All the resources were being sucked into taking care of just COVID patients. You're absolutely right.
Yeah. In our early days in Guyana, we had tremendous challenges. Human resource, test kits, and hospital facility. Those three main ones.
Sure.
How does that compare to where you practice?
Yeah, we were running into the same problems as well initially. And like I said, this was something that we were reacting to, and no matter how much planning you do, I always tell about Mike Tyson talking about you always have a plan until you get punched in the face, right? So that's really what happened. COVID punched us in the face for the first time it came on the scene in March, or when we started shutting down in early March. As a result of that, what we realized that we didn't have enough test kits, so we were actually limiting who get tested, how we test, and some folks didn't have those resources available to them initially. As a result of that, we saw that what the effect of that is that we need more PPE. One of the reasons, I'll give you an example, one of the reasons why we actually limited how many patients come into the hospital for an operation is we did not have enough PPE to take care of the patients in the wards and then provide the same PPE for folks who were in the operating room and other parts of the hospital. So you almost had to close part of your hospital to conserve resources so you can dedicate it to take care of COVID patients.
Wow. That's very interesting, and you're quite right. Not prepared, or you have a plan until you get punched in the mouth.
Correct.
So Just for perspectives, tell us a little bit about the size of your hospital in terms of the number of patients in your ICUs, for example, or your hospital network. Because we in Guyana, our biggest hospital, the Georgetown Public Hospital Corporation, has been designed initially as a 500-bed hospital, and I believe for COVID we had 32 beds dedicated ICU. How does that compare? Where you are practicing now, what are your numbers like?
So we have small community hospitals and we have the big academic hospital within the University of Pennsylvania. One of the things that we noticed is that we had in one of our small, I give you an example of kind of how patients were kind of concentrated. In one of our smaller hospitals, we had 100 COVID patients in the hospital at one time, with about 30 to 40% of them being in the ICU, and about 10 to 15% being on a ventilator. Our larger hospitals, typically which is kind of in the downtown city area, 750 beds. We're actually building a 1,000-bed hospital right now, increasing the capacity in that one facility. They typically, on average, run about 70 to 80 patients in the ICU. And we saw this actually... 70 to
80 patients in an ICU?
In an ICU, correct.
Wow.
Correct.
So that's like 3 times our largest ICU capacity.
Correct.
In one hospital?
In one hospital.
Right.
So what we decided to do at one point, we have several different ICUs in the hospital. So we were able to kind of take one ICU and make that ICU a clean ICU. And all the other ICUs were actually dedicated to take care of COVID patients. You know, one of the things that as a regional program is that we put patient on kind of a heart-lung machine if the lungs are so bad that the ventilator is no longer working, all the medication we provide them are not working. We then have to remove the lung and the heart as part of, pretty much an artificial heart and lung to take care of the breathing and the pumping of the blood of the body. That's when you get to one extreme. And one of our hospitals at one point had about 12 of those patients on those machines. Yeah.
How many of those patients survived? Do you know?
Yeah, the survival rate initially were pretty low, typically about 20%, and we've gotten a little better with anything else. We looked at with COVID.
It's a learning curve.
It's a learning curve, and we are about 50% on as far as survival. What do you imagine? You're at the worst stage of it when you go on one of those machines.
But it's still remarkable to move from 12% survival or 20% survival to now 50% survival, and it's less than a year.
Correct.
So that's a great improvement. And we've learned a lot of clinical management lessons in this entire COVID season. Now, the other challenge that we had was personnel.
Yes.
Did you have to do anything special, anything extraordinary to increase that personnel capacity, the human resource capital?
Yeah, and that's another reason why I mentioned the PPE, so redirecting staff. As you can imagine, there are screening locations that come into the hospital now because of COVID. There are all these different new screening processes that you have to undergo. And we didn't have the bodies to do that. So what we actually have folks do, move from the operating room. So our techs from the operating room went and did some of the screening for patients. Our ICU nurses and our OR nurses worked side by side in the ICU to take care of these patients. So we moved our resources within the hospital. Then what happened? We then overwhelmed those resources after reallocating them or redistributing them. So then we had to go for outside help. We at one point had the armed forces send some of their nurses in to help out with some of those cases. So resources, human resources, was a significant challenge for us as well.
So you mentioned the armed forces. Were these regular Army or Reserve or National Guard?
We had both National Guard and Reserve that came in. Their medical personnel came in to help out. And they will come in, again, throw a hotspot, assist with care for a 2 to 4 week period, and then when things are relatively stable, then move on to another location.
Do you think that's a doable or a good strategy for Guyana to have in terms of human resource capital and building capacity to invest in more persons in the reserves of the military or the Army Corps?
Well, I think, you can never anticipate when a disaster is going to hit on a national scale. And I think more people that you can cross-train and allow them to be able to have a dual purpose of functionality would help. So let's just say you provide some segment of that population with that cross-training in the medical aspect of things. They can then again, get a very short, quick reorientation to the ICU or the operating room and help out in those situations when you have limited resources. So I think it's a great idea. I think it'll always work, and it's very transferable.
Yeah. Well, I'm asking you because I'm a reserve officer in the Guyana Defense Force.
Yes.
So thank you very much, Dr. Vigilance. It's been a pleasure speaking to you today. And for those of you who are watching or listening, thank you very much for joining us. We've been talking to Dr. Dion Vigilance, cardiac surgeon in the United States, but of Guyanese roots. He was born and raised here for a number of years before moving to the U.S. When we come back tomorrow, we'll continue our conversations with Dr. Dion Vigilance. Remember, if you have any questions or comments, feel free to send us a WhatsApp to 620-6275, or you may send an email to docandcovid@gmail.com. Thank you once again.